So welcome to Clinical Pharmacology 1. We're going to start off with our bugs and drugs. So this is a big section. I figure it's good to hit the ground running with some of this stuff. This is stuff you're going to use for the rest of the didactic year. You're going to use this for the rest of your clinical year. And guess what? Also the rest of your entire careers, just in general. And so this is so important. We're going to cover this. That I want you to start thinking about this. Start integrating this with things like your CMS courses, your pathophys courses, your micro courses. All this is going to get repeated quite a bit, and so we're going to try to integrate that all together. Just today, I'm going to go over a quick course overview. We'll talk a little bit about the lecture schedule. I did post up the lecture schedule, so that should be. It's a little bit subject to change based on how things go, but I try to make it mirror the topics mirror the CMS courses as best as possible, right? So there might not be 100% overlap, but it should be pretty good where, once you get into Pulm, your CMS course, you should be getting into some Pulm drugs here as well. It might be one before the other, but it should be pretty good. I also posted up a few helpful links, if you guys noticed. One, I put up a kind of a top 200 drug list that is based on the number of prescriptions that were filled at pharmacies. So that's a pretty good idea of like what are the most common things that people are filling. So when you're thinking about drugs that you really want to like try to ingrain into your memory because you're probably going to be using them pretty often, that's a pretty good list to start with, right? You're going to learn way more than 200 drugs, but it sounds a little scary, but that's a good place to start. I also posted up a few, not that I have any particular stock in Walmart or Publix, but I did post up their free drug list because, again, when you're prescribing drugs for patients, one of the biggest things that comes down to as whether or not they fill it is cost, right? So can they afford the drugs you're prescribing for them? Obviously, if they cannot afford it, they're not going to get it, right? And so, of course, the drug's not going to work if they're not taking it. So I posted at the Walmart. They have a cheap drug list. We have a kind of a $4 list or like $10 for 3 months, sort of thing. So you can get an idea for what those kind of common drugs they cover. Also put up the Publix list. They have a certain small section of free drugs, including things like 14 days of antibiotics, certain other kind of chronic meds like hyperlipidemia meds or antihypertensives, things like that. So those are good meds to kind of get into your memory to think like, okay, these are things that are going to be pretty common. These are things my patients are most likely going to be able to fill, especially if they have issues with insurance and depending on how the political landscape goes and depending on how healthcare goes, that can be much more of a big issue for a larger number of patients. So just something to consider. The only thing I will personally endorse is just Publix subs. The drugs I can't really say for good or bad, but their deli is the bomb. Just so you know, the course is going to be based on a total of 3 exams. You need to have, again, a 75% average in order to pass the course. There'll be 50 multiple choice questions. This will be very similar. I don't like to do a lot of questions of like, which one of these is a beta-lactam antibiotic? They'll have a few of those questions, but I want you to get into the ability to kind of look at a clinical scenario, be able to apply the knowledge you know about the drugs to make a good decision about what drug is best for your patient. So we'll have a lot more questions like that. And the reviews will kind of give you some good ideas about what type of questions will be on the exams. And we'll kind of talk about it as we go forward. I'm also going to recommend, have you guys heard of Exam Master? Okay, so Exam Master also is good for pharmacology questions. I would recommend that you can look up pharm questions there as well. There's also, if you go to Access Pharmacy, it's another database you can get to from the library website. It's very similar to Access Medicine. Have you guys been there before? Yeah, so it's very similar to that. There's Access Pharmacy, which is hosted by the pharmacy school, and basically you can do review questions there. You have to sign up for a free account. It's called like My Access or something like that. You sign up for that, and you can also look at things like Goodman and Gilman's, which was the recommended book on the syllabus. There's also another good book called DePiro, is the author, but Pharmacotherapy is the name of the book. That's also another good book where I pull a lot of information for my lectures. So those are good places to look to do review questions. If you do a question, you're like, hey, this kind of contradicts what Dr. Wood said, feel free to bring it to me. We can talk about it. We can see, and again, because in medicine, you're going to learn that is everything black and white? Certainly not. It's a lot more of an art than it is science in a lot of cases, and so you're going to see that what I may do may be different than what someone else might do, and so we can see some discrepancies there. So anyway. So the objectives, we're going to use all that information you learned in pharmacodynamics. You guys remember all that stuff, right? Hopefully. Okay, we're going to apply that now to all these different types of drugs. We're going to talk about their kinetics. We're going to talk about their distribution, their metabolism, their absorption, all that good stuff. We're going to look at things like, what are the basis for drug interactions? When patients take multiple medications, what are those things that predispose them to having a drug interaction, which may make things more toxic or may make things less effective in some cases. We'll also talk about, when we go over individual drugs, what their very significant adverse drug reactions are going to be, because those are the big things you're going to be educating patients to look for, right? So for instance, I always gripe about patients who come in with a penicillin allergy, right? So they say, oh, I'm allergic to penicillins, and basically it cuts out a huge amount of drugs, as we'll see from them ever receiving. And you go, what was your reaction? So, oh, I had diarrhea. Okay, that's not an adverse. That's not an allergy. That's just an adverse reaction. So by knowing that, you can kind of discern. Okay, well, what are the things that I really need to be worried about? And so you can say, like, well, this patient can probably receive penicillins. Let's go ahead and try it and see what happens, right? So those are the kind of things we're going to learn about. We're going to learn about all these different factors that go into deciding what drug is best for my patient. Just more covering the same things we're talking about here, but I want to get into. And these are all the things we're going to learn about the individual drugs. So we're going to learn about things like the mechanism of action. What does that mean to you guys? Yeah, so it kind of goes back to those pharmacodynamics of like how the drug is working on the body to cause its mechanism to have its effect, whatever it happens to be. We'll talk about indications for use, which are going to be really important because you want to make sure that when you give a drug to a patient, you're giving it to the appropriate patient to make sure that they have the right indication for it. So obviously, when you look at a drug, it'll have a list of approved indications. Does that mean that's the only thing you can use those drugs for? No, what do you call when you use a drug for a non-approved indication? Yeah, it's off-label use of a drug. So certainly you can use a lot of drugs off-label. We'll talk about those as well. It's not like you're doing anything illegal when you use a drug off-label. It's just one of those things that the drug companies did not apply for approval for. Right? When they go through the FDA and they go through that whole process, like they have a list of things they get approved for. We use the drug sometimes for a lot of things that were not on that list to begin with. Contraindications, which would mean who can't have the drug, right? So it's important to say, are pregnant patients excluded from getting this drug? Are patients with certain genetic conditions predisposed or, contraindicated from getting it? Those are kind of things we're going to look at. Obviously, side effects, adverse reactions. We're going to look at some of the follow-up and monitoring. So how do we actually monitor these drugs to see if they're being effective? Sometimes it can be as easy as looking at their blood pressure. Sometimes you have to monitor things like monitoring for drug levels, like we talked about that therapeutic drug monitoring. That's going to come up with certain drugs as well, especially here in the antibiotic section. Some things are going to be a little bit more nebulous. So for instance, like if you had a patient who had an infection, how would you know if the antibiotics are working? Their symptoms are going away, so maybe their fever is coming down, maybe their white count's going down. Like it's a little bit more nebulous in sometimes how you're determining if drugs are being effective or not. So we'll talk about the different ways that we can kind of look to see if these drugs are being effective. Look at things like treatment of drug interactions and how those will kind of manifest, about drug toxicity, and then also things we can do for kind of safe medication practices to make sure that we are using drugs effectively, we're not using them for the wrong patients, and we're not using them to cause errors potentially. So. If you were to, I don't endorse any particular set of drug flashcards. What I would recommend is if you learn best from flashcards, use them, whatever set you get from wherever. Like I said, I don't really endorse one versus another, but make sure that you are at least getting these kind of main facts, right? These are the big things we're going to talk about. And so it's important to distinguish the things you want to kind of focus on as far as your memory goes for these drugs versus things that you can kind of take as a little bit more for granted. So for instance, with antibiotics, one of the big side effects from almost all these antibiotics is stomach upset, right? Almost any drug you can say causes stomach upset. Do you need to memorize for every single drug that can cause stomach upset? Not really, right? So you want to learn those things that are kind of going to be unique features of specific drugs that you can kind of ingrain into your memory. So we'll go over examples of those, but these are things you want to be able to highlight on some of these note cards, right? Or if there's certain things that we don't really go over, like you can scratch things out, kind of adapt them to be more important for kind of what we're covering here. Because again, I'm not going to go over every single side effect, every single indication, every single contraindication. I'm going to go over the things that are clinically applicable, right? Because you guys are not going to be pharmacists. You'll have pharmacists out there that can help you, but you need to know at least the basics in order to make sure you're not going to kill anyone and that you can at least take care of your patients effectively, right? Because again, in a lot of cases, these are some of the most dangerous things you can give to patients in a routine course. And again, most of your patients are going to get some of these with most visits, right? So that's why it's so important we at least have the basics down. This class is not the end all of pharmacology. Like I said, you guys get basically 3 semesters worth of pharm curriculum. I guess technically 4 with the clin pharm next, or when you before you go into your clinical year. But you're not going to learn everything, right? I didn't learn everything in 4 years of pharmacy school. You guys are not going to learn everything in this course of teaching. Always use your references in the real world when you're out there and you're doing things. You never want to do things and not ask the questions. Sometimes when you go and you're treating a patient or you're making a decision, like you always have that thing in the back of your mind, saying, like, is this right? Should I be doing this? Always trust that instinct and go back and make sure you're checking things like references. So look at your guidelines. We'll talk about where you can find specific guidelines to help us make good clinical decisions. We'll talk about our textbooks we can look at, certain online references. So if you guys had to go and look up how to treat a certain disease, where would you guys go? Up to date, right? Everyone says up to date, right? Which is, for the most part, 99% of the time is going to be perfect, right? You can go and at least get a very good overview of how to treat things. You get a lot of good details there. There are other online references you can try as well. There are a lot of drug references that are out there that you can utilize. So for instance, Up to Date is owned by the same company that owns Lexicomp, and that's one of our go-to drug references. And so if you click on a drug within Up to Date, it'll usually take you over to Lexicomp, and that's one of my go-to drug references that we use. It's our standard we use over at Nemours. Depending on where you practice, you'll use different ones. So there's Micromedics, there's clinical pharmacology, lots of different references, but they all have basically the same sort of drug information, just a matter of how they present the info. And then also reach out to your friendly pharmacist. Obviously, if you're working kind of in a standalone clinic, you may not have access to them, but always feel free to, if you're in the hospital setting, like call the pharmacy department. There's someone always there who's happy to talk to you and kind of guide you through any kind of questions you have. It's funny where a lot of the when I talk to the overnight pharmacists that work in Nemours, a lot of times the docs will call up because they're overnight. There's not really anyone else there, and they're not even really looking for necessarily an answer. They're just trying to bounce ideas off of somebody, right? So utilize your resources, talk to people in order to make sure that hey, this sounds good, because again, two heads are always better than one in a lot of cases. We also respond very well to gifts, so don't forget that. Again, this is as much of an art as it is a science. In some cases, more art than science. So again, things are rarely black and white. What I may do to treat a patient is not the same as Dr. McClary would do, or as Professor Quinones would do. Everyone's a little bit different. So just because I say this is the way we do things does not mean that's not the way that other people will do things. So there's no point in going and saying, well, Dr. Wood said this, so obviously this is wrong. That's not the case, right? So there's always going to be a little bit difference. The thing is, you want to come back and ask, like, well, why is that different? Why do you recommend this versus this? And oftentimes we have some kind of sort of some sort of reason why we do that. So again, always ask the question. Don't just assume that one person is wrong or right based on what's in a slide set. Because then we all have different backgrounds. I'm obviously coming from the pharmacist background, from tox, from peds. Other people are coming from behavioral health backgrounds. People coming from EMS backgrounds. So we all have different perspectives, and that's why we have some of these discrepancies here that you'll see. And again, always ask questions if something doesn't look right. If you're looking at a drug order, if you're writing a prescription, you're like, this just doesn't seem right. Double check yourself. Always, 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 because it's really easy to correct that error in the first place rather than having to go kind of eat crow later and say you made a mistake. So let's start with our infectious disease and miscellaneous agents. A little bit of micro review as it pertains to our drug use. You guys have already had one micro class. You guys are already experts in microbiology, correct? Okay, I'm no microbiology expert either, and that's okay, right? So I know a lot about the drugs. Certainly, some people could go much more in depth on the actual the bacteria. I will give you guys the overview, what you need to know, at least for prescribing certain drugs. So we're going to go a little bit over micro review. First thing we're looking at are gram stains. So what does a gram stain tell us? Gram positive or gram negative, right? And so this is oftentimes one of the first bits of clinical information that you're going to get when you are evaluating a patient, right? So you do your physical examination. You're going to go ahead and take a culture. So where can we take cultures from? Take it from the mouth, the nose, a wound. Take it from a joint, you can take it from the cerebral spinal fluid. You can take these cultures from anywhere. And then one of the first things you do is submit to a gram stain, right? And so this tells us if it's gram positive or gram negative. And this is one of the first things that we'll do in order to guide and help us to choose what is the best antibiotic for this patient. So have I talked about the term empiric therapy before? What do you think empiric therapy means? Yeah. Yeah, so we don't know what the actual bacteria is, right? So we may not know what this person has when they're coming in, but based on their signs and symptoms, based on their presentation, and sometimes based on these preliminary results of these gram stains, we can have an idea of what is most likely to be infecting this patient, and based on that, we can say, well, these are the drugs that are most likely going to cover this, right? You'll find that empiric therapy is generally going to be pretty broad in coverage, meaning that we're going to use drugs that are going to cover multiple types of bacteria. And then as you get these results back, once you can actually culture out and determine what type of bacteria it is, you will scale down therapy to make it much more narrow. So that way you're using drugs that will only cover a few specific bacteria. And what's the benefit of doing that? Okay, so yeah, so we use empiric therapy so we can start treatment early. That's absolutely a good reason. But why do we scale down that therapy? Resistance, yeah, absolutely. So as I said, the things that will most likely lead to humanity's downfall, either zombies or nuclear war actually is moving up to the top of the list as of recent, but also superbugs are probably going to be the other thing that will take us down, right? Because of this resistance, because of overuse of broad spectrum antibiotics that cover a lot of different bacteria, you get a lot of resistant types. And so that means that sometimes for certain, depending on where you work, because again, this is very much location based as well, you may find that if you go and work somewhere like downtown Orlando, the type of bacteria that are there and the type of resistances you're going to see are going to be much different than you'd see, say, if you worked in Denver, Colorado, right? So there's locational differences there. But resistance can be a big factor in deciding what type of antibiotics you use. And may lead you to not use one type of antibiotic completely because you know that every type of bug is going to be resistant to that. And so that's one of the big trends that we're seeing is the overuse of things like Z-Paks, overuse of things like Levaquin are leading us to have very resistant bugs that make those drugs much less useful. So we'll talk more about that as we go forward. But basically the first thing we'll do when we have that culture is determine gram positive or gram negative. That kind of gives us a pretty broad idea of what type of bacteria we're going to be dealing with in a lot of cases. Oftentimes you can get things like the morphology of the bacteria as well. So if you hear saying things like gram-negative rods, or if you hear gram-positive cocci, those are other things that will lead you to think certain types of bacteria that will lead you down certain pathways. So we'll look at that as well. Again, so knowing the most likely causative gram-positive cocci, so this is a very kind of broad spectrum or broad group of gram-positive bacteria we can see potentially causing disease for our patients. Where do you think a lot of these bacteria live? This is gram-positive. Yeah, so we see a lot of skin flora that's going to be popping up here. So you guys are creepy and crawling with bacteria all over you right now. Doesn't matter how well you take a shower, you're still going to have lots of bacteria on it, which is gross, but an unfortunate reality. Which is why when you're thinking things like skin infections, you're going to think like, well, what bacteria was there on the skin in the first place? And so you're going to go back to thinking, what type of disease state am I dealing with? What are the most likely bacteria that are going to be causing this disease? And so going off first the gram positives, the first thing we're going to be looking at is going to be our Staphylococci. These can kind of be broken down broadly into coagulase positive or coagulase negative. Again, these are things that will show up when you're doing your cultures, and that results will come back. So you think about things, when you see coag positive staph, you're going to be thinking about things like Staphylococcus aureus. So I'm sure everyone's heard of the dreaded MRSA, right? What does that stand for? Right. What is methicillin? Yeah. So it's an antibiotic. We don't really clinically use it ever anymore, but it is in what class do you think it would be in? Yeah, it's in the penicillin class. So it's kind of already telling us like, okay, is this Staph aureus going to be resistant to our penicillins or not? And so we can look at some of the drugs and specifically how that will have coverage there. But basically, Staph aureus will be broken down into MSSA, which is methicillin sensitive Staph aureus, or MRSA, or methicillin resistant. Which one do you think is more clinically severe? Yeah, MRSA is always going to be worse, right? So MRSA is more resistant. You have less antibiotic options that will cover that. And so this is why we're much more worried about, like, if you hear MRSA pneumonia, that's a bad thing, right? Because, again, you don't expect a lot of gram-positive bugs in the respiratory tract in the first place, especially down in the lungs. If you hear MRSA, that's usually not a good thing, right? So think MRSA, think bad infections. And, again, with more resistance, it's going to be harder and harder to treat those. Coag negative, usually you're thinking Staph epidermidis, right? And so where do you think you find that mostly? On the epidermis, right? So you find a lot of this on the skin. This is why in a lot of cases when you do, say for instance, you do a blood culture, right, from a patient, obviously you're having to pierce through what? The skin. So in a lot of the cases, what you'll find is cultures will come back growing Staph epidermidis. And so oftentimes we'll say that it looks like a contaminant. And so that's why in a lot of cases when you do blood cultures, you do it from two different sites. So that way if one comes up Staph epi, and the other one comes up negative, you know it was probably a skin contaminant. You can do your best to try to clean off the site beforehand with alcohol or things like that. A lot of times you can still have contamination though. So Staph epi is a common contaminant. Just because you see that on a culture for a patient does not mean you need to treat that. Okay, so that's another kind of a good takeaway to think about when you see cultures coming on patients. Strep pneumo is going to be a huge bacteria that's going to be responsible for a lot of upper respiratory tract infections, as we'll see. So we're talking about acute otitis media, we're talking about strep pharyngitis, we're talking about rhinosinusitis. A lot of times this comes back to strep pneumo, so we'll see that's going to be a very common causative agent there. This is also another one that we actually have a vaccine against in some cases, right? So we'll look at the pneumococcal vaccine that we have that can be useful against that. And then enterococci, what do you think you find these guys? In the gut, right? So you see a lot of times if you have, for instance, like UTIs, sometimes you can see this where patients, especially female patients, are more prone to things like UTIs due to the kind of close approximation of the urinary tract for like a female patient to the anus. You can see a lot of translocation of bacteria. So if you see an enterococcus, so if you did like a urine culture and you did a gram stain, you saw gram positives there, this is one of the things you might be thinking of, is this enterococcus that could show up there. So again, these are kind of your positive, your gram-positive cocci, kind of the more common ones. This is obviously not going to be a completely exhaustive list, but these are just kind of the most clinically relevant ones you're going to run into in the your normal clinical setting. We also have our anaerobes. What does anaerobe mean? Yeah, they can exist without oxygen. So these are traditionally very difficult to culture because, again, when you have your cultures and you take them out of the patient, oftentimes, what is it exposed to? Oxygen, right? So a lot of times you're going to have a hard time culturing these unless you do specific anaerobic cultures. You can order those specifically, and you can hopefully culture out some of these guys. So you see things like your gram-positive cocci anaerobics. So you things like Peptostreptococcus, Peptococcus. Where do you see these occur at? Does anyone know? These in the mouth a lot. So sometimes you have like an oral infection. Sometimes these anaerobes can be seen there. And then you also have some of these bacilli. So you have things like Clostridium difficile. Does anyone know what that causes? Yes, C. diff, right? So C. diff stands for Clostridium difficile, absolutely. So that's a very, this is called an opportunistic infection. What do you think that means? Possibly for immunocompromised patients or patients who have, say, a disrupted gut flora. So, for instance, there are certain antibiotics that we give. Do you think our antibiotics know the difference between, pathogenic bacteria versus healthy flora? Oftentimes they cannot tell the difference, and so they were going to kill off everything. So in a lot of cases, and especially certain drugs like clindamycin, we'll see, you will wipe out a lot of your gut flora, a lot of those anaerobic bacteria, a lot of those gram-negative bacteria in your gut, and then you will have these opportunistic bugs that will come in and start to cause an infection. So Clostridium difficile is a big one. So if you hear C. diff colitis, causes very, very severe diarrhea, can be very, very significant, very, very significant morbidity associated with that. And sometimes you'll see it in immunocompromised patients, but more often than not, this is a secondary consequence to overuse of antibiotics. So that's a big thing to consider. Also have things like Clostridium perfringens, which you can also see in more anaerobic environments, kind of like the gut. Okay, so moving on, next we have our gram-negative bacilli. So this is another big group of bacteria that are going to cause a lot of diseases. So we have their Enterobacteriaceae. So these are going to include things like your Citrobacter species, Enterobacter, E. coli is another big one here, Klebsiella, Serratia, Proteus, Salmonella, Shigella. This is a very wide group of bacteria that can cause disease. We see these very, very commonly, especially for things like urinary tract infections. You see a lot of E. coli, you see a lot of Proteus, you see a lot of things like that. You'll also see these causing things like lower respiratory tract infections. And so the thing to remember here is you're not going to memorize which antibiotics are going to cover each and every single one of these bacteria. But when we get into specific disease states, when I talk about a pneumonia, you're going to know that, okay, pneumonia, I'm thinking of these type of bacteria. I know that these type of drugs are going to cover it. So you're going to make those kind of associations, but this is why I cover all these here up front, so you at least have some kind of background for it. Another really important anaerobic bacteria that we'll see in the gram-negative side is going to be Bacteroides fragilis. We'll talk about this a lot when we get into some of our penicillins and whether or not they have coverage against this, right? And so this is important when you're thinking, like, what type of infection am I dealing with? So, for instance, if I am dealing with, like, say, an appendicitis, right? So the appendix is going to be kind of closely located with which organ system? GI tract, right? So it's one of those big things that we worry about when you have an appendicitis. I worry about translocation of some of these anaerobic gut bacteria. So when I cover a patient, say for surgical prophylaxis, and I'm going to go in and take out their appendix, I need to make sure I cover for some of these anaerobes. And that includes things like Bacteroides fragilis. And so we'll see that when we choose certain antibiotics, this is why we make those decisions, is based on the most likely bacteria that could cause disease, right? So for instance, if I was going to go and say, I think of another good example. So like for an appendectomy, we would certainly cover for anaerobes, but say for instance you're going to go in and do go into surgery and you're going to do say like some sort of orthopedic procedure, right? So say you're manipulating the bones, what type of bacteria do you think would be more likely to cause disease there? What's living on the skin? Yeah, a lot of staph, a lot of the staph epi we talked about. So again, you're going to think like, okay, orthopedic procedures, I don't need to really worry about anaerobic bacteria. I need to worry about my skin flora, right? So you'll find, especially when you get into your rotations, the antibiotic decisions are going to be made based on those kind of most likely causative organisms. So again, we have our Pseudomonas. Who's ever heard of Pseudomonas? Yeah, this is another pretty dreaded bacteria. You don't want to ever culture these out, but you see this a lot like in your ICUs. You see this a lot in your nursing home patients, a lot in patients who have had overuse of antibiotics. This is a very, very bad, this is on the same level as like MRSA, right? And so oftentimes when we're dealing with like really severe septic patients coming into the ICU, oftentimes we're worried about MRSA. So we cover for that, and we're worried about Pseudomonas, and we'll cover for that as well. So we'll talk about how we do that. You also have some other bacteria that you may not see in most healthy patients, so things like Stenotrophomonas. This is a bacteria you see a lot in cystic fibrosis patients, usually in kind of more late course for that. We'll talk more about cystic fibrosis when we get to like a peds section in pharm. Acinetobacter is another really bad one that you'll see in very sick ICU patients. Again, most healthy patients do not get infected with this. We have good immune systems that can fight against that, but sometimes you'll see these pop up in those very, very ill patients. Some other ones you'll see as well include things like Haemophilus influenza, Moraxella catarrhalis. These are very significant for upper respiratory tract infections, for ENT type of infections. So we'll look at this pretty extensively in the upcoming lectures. And then you also have things like Neisseria gonorrhea, Neisseria meningitis. What do you think what type of infection would you see with that? Meningitis, yeah. So when you think about Neisseria meningitis, like these are the type of things you're going to be looking for. And so, for instance, we had a case of Neisseria meningitis actually a couple months ago at Nemours, and it's one of those things where like sometimes the clinical presentation will back up what type of infection you think it is. So this one patient had basically petechial hemorrhage all over the body, and that was a very clear sign. And especially when patient presented with meningitis, also had these petechia all over, that was a clear sign that hey, this is probably Neisseria. These are the type of antibiotics we need to use. So sometimes the clinical presentation will help with that as well. So, and I include here the space or the escape bugs. Simply, these are going to be pathogens. These are gram-negative bacilli that are more likely to develop pretty significant resistance. Okay, we'll see that sometimes you can actually have bacteria that will develop resistance against one type of antibiotic, and it'll actually share that resistance with other types of bacteria. So now you have like this kind of resistance movement happening with your bacteria that make it very, very difficult to treat in a lot of cases. So these are going to include things like your E. coli, your Serratia, your Klebsiella, Acinetobacter, Pseudomonas, and this is kind of a general Enterobacteriaceae. So again, don't need to memorize this list for my purposes necessarily, but just know that when you hear space, you hear escape, think about really virulent gram-negative bugs. Think about very difficult to treat resistant type of bacteria. Okay. Also, we'll talk about atypical pathogens. So when you hear things like atypical coverage, you hear about atypical pneumonias. This is what we're talking about. So these include things like the chlamydia species, so chlamydia pneumoniae, trachomatis, Legionella. You guys know where the Legionella bacteria got its name from? Yeah, so it came from, there's an American Legion meeting that was happening in this hotel, and basically the AC system got infected with all these, this Legionella. It didn't have the name at the time, but basically all these patients came down, these old vets, ended up coming down with this pneumonia. They couldn't figure out what the heck was going on, so they eventually, found the bacteria, realized it went back to the AC system, and got the name there. But anyway, small digression. And then also mycoplasma pneumonia is another big atypical you'll see. So again, we talk about things like respiratory tract infections, like these atypical bugs will come up again. Okay. This is also kind of a helpful slide that will kind of guide you to saying, okay, well, if I have a specific type of infection, what are the bugs that are most likely to cause that infection? So again, you don't have to memorize this entire list. This will come up when we talk about these disease states in their individual sections, right? So when you talk about pulmonary pulmonary system, we'll talk about pulmonary infections there, and we talk about those different things. So for instance, though, you'll kind of see some trends here. So for instance, skin and soft tissue infections, right? So think about things like your cellulitis, think about things like your abscesses. You're going to find a lot of these gram-positive bugs, things like Staph aureus, Staph epidermidis, Streptococcus. So you'll think like, okay, well, I want antibiotics that can cover those type of bugs. Okay, so again, your coverage needs to match what your most likely organisms are going to be. Versus something like, say, meningitis, you're going to see a much more. You see some gram positives, but you also see some gram negatives popping up here as well. So things like Haemophilus influenza. Certain patients will be more likely to certain infections than others, or certain bacteria. So, for instance, when you're looking at Listeria. Listeria is a pathogen that you don't really cover for meningitis unless the patient is very young or very old. Because again, at those extremes of age, what happens to their immune system? Usually becomes compromised, either for like the neonates or the infants. Like they often don't have a very well developed immune system. Older patients, they typically kind of have a waning immune system. They're more likely to have Listeria pop up there. So again, your coverage is going to be determined also by the patient's presentation, their individual factors, and it will guide you to choosing one drug versus another. And a lot of this is going to be stated out in things like guidelines and your drug references. They'll tell you if you're dealing with a patient who's 70 years old, these are the, and for meningitis, these are the type of antibiotics you want to use to cover for these bacteria. Okay. Again, I mentioned in the mouth, you're going to see a lot of anaerobes here. So again, you're going to think about anaerobic coverage for those. We'll see that only certain antibiotics will cover for those type of things. Urinary tract, you're going to see a lot of gram-negative bacteria. Sometimes you'll see things like anaerococcus pop up, though, again, due to usually translocation from gut flora, gut bacteria there. And again, think about things like, well, does the patient have an indwelling catheter, right? So if you have a piece of foreign material and foreign plastic going into the bladder, that is a very easy way for bacteria to translocate into the urinary tract, right? So anytime you have a patient has kind of a permanent piece of hardware, or not permanent, sorry, but a piece of hardware that is invading into the body, you're more likely to see infection via those routes. So think about things that have IV lines for too long a period of time. You can see bacteremia pop up there. Think about patients who have an endotracheal tube, or likely to see pneumonias, because you can have bacteria that will translocate through, through that plastic into the respiratory tract. So think about things like that as well. And those are usually where you see kind of abnormal bacteria start to pop up. So that's where you see like Staph aureus pneumonias is usually due to intubated patients. It's one of the things you'll see there. Okay. Again, upper respiratory tract, we're going to cover this pretty extensively in the next couple sections, but you'll see things like strep pneumo, H. influenzae, Moraxella catarrhalis. These are all going to be really big bacteria that we're going to cover for empirically. Lower respiratory tract, you're going to see some crossover here, but this is where you can also see things like some atypical bugs like Legionella, Mycoplasma pop up there as well. So, and then so we have this distinction between community and nosocomial. What does nosocomial mean? Yeah, so basically, I always tell people that the hospital is one of the worst places to get healthy, right? Because it is pretty gross there for the most part. There's bacteria everywhere from other patients, and so you can see cross-contamination. Sometimes you'll actually have whole wings of an ICU have to be closed down for a terminal clean because you can have kind of rampant spread of some of these really resistant bugs just because of nurse going from room to room or the doctor goes from room to room, whoever can spread these bugs pretty easily. But these are things you get in the hospital. They are typically much more resistant, much more difficult to treat. So you see much more higher incidence of MRSA, Pseudomonas, Klebsiella. These are where the really nasty bugs start to pop up, right? So we'll look at that when we get to the pulmonary section. Okay, so this is anyone ever heard of or seen an antibiogram before? All right, so this is a very useful tool. A lot of people do not take the time to look at these when they go to work, say, in a new institution. But I really encourage you to just ask somebody if you go to like on your rotations, you're like, hey, do you have an antibiogram I can check out? Usually they'll have one available. And basically what this does is it will look at a group of bacteria, usually have a list of your gram negatives and your gram positives, and it will have a list of the different antibiotics here across the top. And so basically what this will tell you is that based on the isolates that the hospital has cultured from that particular those patients that show up there, they can say that this for this bug it was sensitive to this antibiotic in this percentage of cases. So for instance, if I was looking at treating, say, something like E. coli, I can see here that a drug like amoxicillin clavulanic acid or augmentin, you see that 88% of the time that it was sensitive to E. coli. Okay, so it means it would be useful for treating that infection 88% of the time. Now, is that necessarily good enough for treating your patient? Do you want to be 88% sure that you're going to treat that infection? Probably want a little higher than that, right? You probably want something that's a little bit more surefire. So you can see, okay, well, ampicillin is not going to be any good here. It's only 65% susceptible. But maybe I can use something like, oh, let me try using like cefazolin, right? Or cefazolin, however you want to say it, is 94%. That's a lot better, right? Sometimes you can go with things like, imipenem. So we'll see that sometimes you can have drugs that can be very, very sensitive for some of these bacteria, but sometimes their spectrum is too broad and you may not want to use that. So again, just take a look at one of these if you ever go. You'll see that this will be different depending on where you're working at, and it really requires you having kind of a robust number of isolates to look at. So for instance, for E. coli, they had 1,002 isolates there to look at, and so that's a pretty good number to draw from to determine what the sensitivities are for that bacteria. Versus something that would be much less likely to show up in something much less common, something like Enterococcus faecalis that's resistant to vancomycin. There's only 2 isolates of that, so it's a pretty rare thing. But depending on where you work, you'll find there's different kind of spectrum there. You'll have different resistance patterns, which is important to know because again, it may lead you to choosing one antibiotic versus another in almost all patients. So for instance, for cellulitis, if you know your MRSA your community-acquired MRSA is going to be always resistant to clindamycin, I'm never going to use that. I'm going to use Bactrim instead. So we'll look at those distinctions a little bit later. So very useful to look at these. Use these when you find a final place to settle down and practice at. That makes sense? In a lot of cases, if you don't have enough isolates, you can't really do a good antibiogram. So for instance, when we opened up Nemours back in 2012, we didn't have any isolates to pull from, so we had no idea what type of resistances we were going to see. So what we did is we actually were able to, the medical field's a very small world, so we were able to, use some of our friends over APH and grab their antibiogram as a starter guide, at least, to say, well, patients in the Orlando area are most likely to have bacteria that kind of represent these type of sensitivities. Let's go ahead and use that as our standard for now until we get our own isolates and determine, hey, maybe there's something different about the Lake Nona area versus something like the downtown Orlando area, right? So how do we know whether a bug is going to be sensitive or resistant to an antibiotic? Okay, so these are some of the ways we can do this. This is anyone know what this is called? Well, yeah, so it's an agar plate, right? So you basically culture out the bacteria, you let it grow all over this, and then we're going to actually, this is called a disc diffusion test. So this is where you actually will have different antibiotics that are being set down into this plate. And so what do you notice around where you put the antibiotic? Yeah, so it's killing off the bacteria. So based on this, and where would you assume the highest concentration of antibiotic was? Well, right at the disc, right? So right at the disc, you have the highest concentrations, and as it passively diffuses, you see lower and lower concentrations. So based on the size of this area of inhibition, you can see how sensitive the bacteria would be to that particular antibiotic. So notice here, this has a pretty big circle around it versus, say, this antibiotic did not really make that clear of a circle there, or even as big. So that would say, well, this one's probably more sensitive than this one would be. So that's one way you can determine how sensitive a bacteria is going to be. And when you get culture results back, it'll usually say, hey, patient grew out E. coli, here's what it was resistant to, here's what it was susceptible to, and then you make your decision on what you want to treat with. Right? So that's oftentimes how the decision goes. Yes, ma'am. So this would be a disc diffusion test. Right? So that's one way you can check for resistance to or susceptibility of these antibiotics. The other way you can do it is actually you can use, I'm not sure if there's, I'm sure there's a specific name for it, I'm sure somebody Dr. McClary could tell you, but basically here's a strip that is impregnated with different concentrations of the antibiotic. And so you can see here, this is a much more specific test to see just how resistant the bacteria might be to this antibiotic. You can see here that the highest concentrations are going to be located at this end of the strip. So obviously you have the biggest zone of inhibition, and then as you get farther and farther along, the concentrations dip, and notice how it's less able to keep the bacteria from growing there. So that can tell you, say, okay, well, this concentration is enough to get a pretty good kill of the bacteria. Anything below this, would be insufficient, right? So that could be, and again, you can overcome resistance for these bacteria by giving a big enough dose of an antibiotic. But what happens when you keep increasing doses of your antibiotics for your patient? Side effects, right? And so that's the balancing act we're trying to have here is between killing our patient and killing off the bacteria. Oftentimes, you want to kill the bacteria, but you want to leave your patient alive, typically. Okay, so that's a big thing to note there. Okay, so looking at resistance, that's a pretty good location of my laser pointer. But controlling the emergence of resistance, how do we do that? This is not how you should decide how to use antibiotics for your patient, although it may seem that way, at least to the untrained. It's like, okay, well, what do I think? Let's use some penicillin G, and then we're going to use it for 14 days. No, you shouldn't do it this way. It needs to be very regimented. It should be very predictable what type of antibiotics you're going to use for your patients based on their presentation. So why is this such a concern? We're seeing a lot of resistance coming up, especially with gram-positive bugs. So this is things like MRSA. This has methicillin-resistant Staph aureus. We also have things like vancomycin-resistant Enterococcus. So vancomycin, we'll learn, is a very, very potent gram-positive killer. but you have some bugs that are even resistant to that. You have VRSA, which is vancomycin-resistant Staph aureus. That's even worse, right? Because now you have Staph aureus that's resistant to almost everything. And so the problem is that as you get more and more resistant bugs, the number of drugs you can use to treat that infection goes down pretty precipitously, right? And if you're thinking about, a drug company, if you're, what's your primary goal as a drug company? Money, right? So you want to make money for your shareholders, right? That's the primary drive. As much as we'd like to think these drug companies are altruistic and they want to make everyone in the world healthy, probably not the case, right? But they want to make money. And so if you're thinking about it, like, okay, should I put money into making a drug that is going to treat, say, hypertension, which I know millions and millions and millions of people have, or should I make a drug that's only going to be able to treat this infection that is very, very rare, that will pop up, say, only maybe a couple thousand times a year? You go with the blockbuster drug, right? So that's why we see there's less development of a lot of these antibiotics. We get very, very few new antibiotics coming out every year versus the number of new ways to treat things like, we see these monoclonal antibodies for things like these rheumatoid conditions. We see new ones coming out all the time. They're grossly expensive, but they're coming out constantly versus antibiotics. We may get 1 or 2 new ones a year, and oftentimes they may not be really good for treating some of these more resistant bugs. So it's one of those things where we need to curtail this resistance, otherwise these bugs are going to be the ones taking over, right? So it's no good. We also see gram-negative resistance is really bad. You have things like your, we call this ESBLs, or extended spectrum beta-lactamases. We'll talk about what those are in a second. We also have these Klebsiella-producing carbapentamases. We'll talk about those a little bit later as well. But basically, these are bacteria that are able to generate products that can inactivate some of our more intensive antibiotics. So again, basically the bacteria learns how to destroy the antibiotic so it can't be effective at killing the bacteria, right? And so you can see that probably 4 these bacteria account for almost 70% of these resistant infections. And notice they have Klebsiella, E. coli, Pseudomonas, and Acinetobacter. Those are part of that escape, or those space bugs, right? So these are very, very virulent, very likely to develop resistance as time goes on. So what are some things that cause resistance to occur here? So indiscriminate antimicrobial use. So if we're not following guidelines, right? So we need to follow guidelines. They've been made based on evidence-based literature to say, hey, these are the most likely drugs to cover this infection. These are the most narrow spectrum we can use. Follow your guidelines, right? You'll never get in trouble for doing that. What do you think double covering is? Yeah, so if I use 2 antibiotics to cover 1 infection, there are very rare cases where that's appropriate. Most of the time it's not. A lot of times you'll see that people will do things because it makes them feel better, right? So it's like, and a lot of times they'll say, hey, can we take off this extra antibiotic for this patient? They're clinically improving, they look better, and the provider will be like, I don't know. Let's just leave it on. Let's leave it on for a few more days and see what happens. So they usually wait until they're off service for someone else to come on and then make that decision. So you don't want to be those kind of providers, though. You want to be able to say, hey, let's go ahead and take off this antibiotic if it's not really necessary. Because, again, you're more likely to see resistance. If we do not de-escalate or streamline therapy, which means we need to go from very broad spectrum, which is appropriate when you're first initially treating a patient, you need to narrow that down based on what your culture results come back as. So, for instance, if I use a really big broad spectrum antibiotic to start off a patient, say for pneumonia, and their culture comes back and it says, hey, it's sensitive to this one very narrow spectrum antibiotic, I need to switch over to that, right, if it's appropriate. If you don't do that, then you're going to, again, see more resistance. We have kind of prolonged therapy. So if you have, if you're treating for too long, again, can lead to resistant bugs popping up here. So that's why the guidelines will tell you, hey, treat for 7 days, treat for 10 days, treat for whatever happens to be based on the evidence. Things like greater than 7 days on mechanical ventilation, as you see this a lot in your ICU patients where they're on a ventilator for a long period of time. You can see that those bacteria start to translocate, start to move down the tube, cause infection. That's a very, very big reason a lot of those patients die is due to these secondary infections here, these nosocomial infections. Prolonged hospital stay, more likely to see resistant bugs there, and then also prior antibiotic use. So this includes things like using either too broad a spectrum antimicrobials. We'll talk about these, but these are, I call these gorillacillins because they are in the penicillin class, roughly, but they are very broad spectrum. They'll kill almost everything, right? But they also leave you much more prone to having resistant infections pop up afterwards. And again, also using prophylaxis antibiotics. So again, using antibiotics without an actual infection needs to be appropriate use. There are some cases where it makes sense, like surgery. There's some cases where it does not make sense. So again, just don't overuse antibiotics is the best thing we can do there. Okay. Big reasons for resistance. Oftentimes it comes back to how we treat a lot of our food. And so a lot of livestock and things like that overuse a lot of antibiotics. And so that can also lead to us getting resistant bugs as well. Does anyone ever, I can't remember the name of that movie. Had Gwyneth Paltrow in it. It wasn't Outbreak. That was the monkey movie. It's Contagion or something like that. Basically, it was a movie where these resistant, animals end up developing the virus that was killing off in half the world. But basically, yeah. So overuse of antibiotics on animals oftentimes leads to resistant bugs for people as well. Have you ever seen MDR? That stands for multi-drug resistant microbes. Okay, so just know that's what that stands for. Okay, so there's lots of reasons why we have our bacteria start to become resistant. So things like, if we have efflux pumps, right? A lot of times our antibiotics will work by getting into the cell and then having their mechanism within an intracellular space. Well, if I have efflux pumps that are shuttling the bacteria, the drugs out, then they can't have their mechanism, right? So that's one way we can prevent the activity of these antibiotics. You can have things like antibiotic modifying enzymes. So you can have the bacteria start to produce enzymes that will actually inactivate your bacteria or the antibiotics and make them less effective. You can see things like changing drug targets. If I start to modify the genetic code for some of these targets, like your proteins and whatnot, that makes it less likely for the drug to bind to it and much less likely to work. Just know that there are lots of ways for bacteria to develop resistance. I'm not going to get into all of them here, but just know that this is a big concern and reason why we want to make sure we're using evidence-based medicine to decide what type of antibiotics to use for our patients. Okay. So some of the ways we can help to manage that. So there's lots of things we can do, especially like in the hospital setting, to try to curtail antimicrobial resistance that pops up. So things like formulary restriction and antibiotic cycling. That means that this is what we do at Nemours, and a lot of hospitals will do this. Is we have an antimicrobial stewardship program. Basically means that we want to make sure that we're having appropriate use of antibiotics. And so in a lot of cases, for certain really broad spectrum, really like kind of hardcore antibiotics, you can't use it unless you have an approval from an ID specialist, right? So basically you have to make your assessment of the patient, say, hey, I really think it's this type of bacteria. I want to use this really hardcore antibiotic. You have to have the ID specialist come on and say, hey, that's okay. Or no, let's try to use this instead. So that way we're trying to encourage interdisciplinary care for our patients. We're trying to make sure we have multiple heads kind of thinking about things to make sure we're making the best decision for them. And we'll do things like cycling out certain antibiotics during certain periods. So for instance, the immune glycosides are a good example where we'll use tobramycin for a long period of time, say for like a year or two, and we'll switch over to use gentamicin. And then after another year or two, we'll switch back. So that way you can prevent resistant bugs from developing resistances against those specific antibiotics. Looking at the duration of treatment, de-escalation of therapy. Using things like following our treatment guidelines. These are all things we can do to try and make sure we're making sure our patients are treated appropriately. One of the big things that you'll find the pharmacist helping with, especially if you're working in the hospital, is going to be this pharmacokinetic and dynamic dose optimization. So that goes back to that therapeutic drug monitoring. We're actually looking at drug levels to make sure a patient's getting a high enough level to treat the bacterial infection without causing toxicity, and make sure we're actually eradicating the infection appropriately. Because again, if you don't give high enough levels to actually treat the bacteria, that's where you see resistance pop up as well, as we'll see in just a little bit. So I will give a 10-minute break now. We'll come back and start to talk about the antibiotics. Any questions from the first half? Are you guys sufficiently scared of antibiotics yet? We haven't gotten into the drugs. Don't worry. It'll be fine. It'll be good. Okay, so when we're choosing a regimen, we're choosing how we want to treat a patient's infection. First thing we're going to look at spectrum of activity, and I've kind of alluded to this. This is basically what bugs the drug will cover, right? So if I'm thinking something like vancomycin, you're going to know intrinsically, especially after this class and after you used it for a while, vancomycin gram-positive bugs, right? I know if I have a gram-positive infection, vancomycin is going to work 99% of the time, right? Things like that. So you'll learn those things over time, to what kind of coverage you'll have out of these antibiotics. You look at the kinetics. Can the patient absorb the drug appropriately if I'm giving it, say, orally? Are they going to have normal distribution? A lot of times we'll have patients who will have, especially septic patients, they end up having a lot of third spacing of fluids, which means we have a lot of fluid going from the intravascular space out into the intracellular space, or the extracellular fluid, and so you end up having altered distribution of a lot of drugs. And then also look at their elimination. This is oftentimes one of the biggest places that, at least from the pharmacy standpoint, that we have interventions is based on the clearance of the drugs for those patients. So one of the big ways that drugs are getting cleared from the body is the kidneys, right, through the urine. And so if your kidneys are not working due to infection, guess what? You might not clear a lot of those drugs. So knowing whether a drug is going to be renally adjusted or not is super, super important. And if you're not sure, check your patient's renal function, check to see if they're going to be able to clear it well. Okay, because again, if you have buildup of a lot of these drugs, that's where we run into problems. It can either cause further kidney damage. You can see ototoxicity for some drugs. You can actually have hearing loss that can occur. Lots of different problems that happen here. So really make sure that their clearance of the drug is going to be appropriate based on patient history and all those different things. We're going to look at the pharmacodynamics of the drug itself. So we'll have this term, whether or not something is bactericidal versus bacteriostatic. Okay, so what do you guys think the differences between those two? Yeah, so something that's bactericidal means it's going to kill the bacteria. Something that's bacteriostatic means it's going to prevent it from reproducing. Okay, because again, when we're giving an antibiotic to a patient, we're not only just relying on the antibiotic to get rid of the infection, we're also relying on what else? The immune system, absolutely. So the patient's immune system plays just as big a role as any of the antibiotics we're going to be giving in order to clear that infection. So in a lot of cases, you can give bacteriostatic antibiotics to a patient, and then their natural immune system is going to come along and be able to wipe out the rest of those bacteria, right? Based on phagocyte action, your macrophages, your neutrophils, all those different things. So that's really good. Now, in some cases, you'll have patients who have really poor immune systems, right? So think about patients who have, they're on cancer treatment, they're immunocompromised. Think about patients who have very severe HIV/AIDS. They're not going to be able to really fight off those infections. And so if you use something that's bacteriostatic, they may not really be able to clear that infection very well. So that's one of the things where we're thinking, well, maybe something that's bactericidal will be more important there. So we'll look at some of those as we go forward. We'll see whether or not some of these antibiotics are cidal versus static. And a lot of times that will make sense based on their mechanisms. So if I have something that's going to blow open a hole in the cell wall of the bacteria, what do you think that's going to be? Cidal or static? It's going to be cidal. If I have something that just inhibits, say, protein production, it's going to be more static, right? So based on the mechanism, you're going to have an idea of whether or not this is going to be bactericidal versus bacteriostatic. And then we're going to look at time-dependent versus concentration-dependent killing. Okay, this means that for some drugs, you want to get to a really high peak level. They'll kill off a bunch of the bacteria, and then you can let that drug level drop almost back down to 0 before the next dose is given. And that's okay. We'll get some graphs of that in a second. Some drugs, you want to make sure you keep at a steady level for as long a time period as possible in order to make sure you kill off as much of the bacteria as we can. We'll go into more detail on that in just a second. I'll show you some graphs that will make more sense of that in just a little bit. And then the other big thing you want to look at is toxicities. GI is going to be a big one. GI upset is going to be a big side effect for most of these antibiotics. You can see issues with hematologic toxicity. Some of these can cause things like thrombocytopenia or agranulocytosis, CNS toxicity, hepatic toxicity, renal toxicity. So we'll look at all these different factors in deciding what antibiotics we're going to use for our patient. So again, when we're looking at bactericidal versus bacteriostatic, so these are going to be things where, again, bactericidal is going to actually disrupt the function of the bacteria so much that it's going to lead to cell death. So we can think about things that work on the cell wall, especially, are going to be things that can kind of prevent further production of cell wall, which will actually lead to lysis of the cell. We'll get some pictures of that in just a little bit. But things like penicillin, cephalosporins, things like vancomycin. And then things that are bacteriostatic are going to be inhibiting, kind of a vital pathway, but are not going to be enough to actually destroy the bacteria itself. So again, we're relying on the patient's host immune system in order to help kind of get rid of the bacteria, since the drugs have kind of put a stop on the reproduction. So this will be things like our macrolides, like erythromycin, tetracyclines. Again, don't memorize this list specifically. We'll look at this more in detail when we get to the specific drug examples. Okay, and then concentration versus time-dependent killing. So concentration-dependent killing means we want a really high drug concentration. The greater the concentration, the greater the killing of the bacteria we're going to see here. Okay, and a lot of times these antibiotics are going to have what we call the post-antibiotic effect, which basically means that even though your drug levels are dropping down to, say, negligible, say the level is 0, if you were to measure the plasma level of the antibiotic, you would still see some of those bacteria being killed off, right? They still are holding on to some of that drug, still having some of that killing effect. And so that is, this will lead to us dosing the drug in one particular type of way, as we'll see in just a minute. Time-dependent killing means that we need to keep the drug level high enough in order to help keep killing those bacteria off. So there's this term called the minimum inhibitory concentration. What do you guys think that means? Yeah, so you need at least this much drug in order, this high of a level, in order to inhibit that bacteria, to either kill them off or to prevent them from reproducing, okay? And so for these time-dependent drugs, you need to keep the level high above the MIC, and so the higher, the longer you keep the drug level above the MIC, the more bacterial killing you're going to have, okay? So this means that we can either give a drug, say, via continuous infusion, right, and that would keep the level very steady, or we can give the drug very frequently. So say, for instance, if you see a drug being given, say, every 6 hours, okay, that means that usually you're going to think that's more of a time-dependent killer, because by the time you give a dose, it's going to, let me try to draw this. Again, you guys know my drawing skills are top-notch. So say, for instance, here we're going to have two different antibiotics we're going to give here. And so say, for instance, here's the minimum inhibitory concentration. So this means we need drug levels. Anything above this is going to be enough to prevent that bacteria from reproducing, okay? So for something like a concentration-dependent killer, we're going to want to get a very high level as you can, and then even if it drops down to nothing, and so imagine we're giving a drug, say, every 24 hours, okay? Even though this level drops down to nothing, you're still going to have that post-antibiotic effect. That bacteria is still going to be inhibited, okay? Still not reproducing yet. On the other hand, if I give either, say, something that's going to be a continuous infusion for something that's a time-dependent killer, you can see here the level will go up, and as long as I keep it above that MIC, I'm still going to have the bacteria being inhibited, right? So that's one way you could do it. The other way you could do it, say, for instance, if I was going to...
Would the one on the left contribute to resistance? Or?
Not necessarily, right? Because you're still having a pretty significant kill of the bacteria. You're wiping out, basically, you kind of like throwing a grenade and just killing off a bunch of the bacteria, and then before the bacteria has a chance to start to repopulate, essentially you're giving another dose of that drug, right? So again, that would be, say, something like every 24-hour dosing. On this hand, this would be, say, a continuous infusion. It's not super practical to give continuous infusions of drugs to patients, though, right? Because that means that you have one line that is always being taken up by that drug. If I need to give other drugs, that can be very difficult to manage. Sometimes patients only have one line, right? So that can be, that your whole line is taken up by that drug is not super useful. On the other hand, though, if I give frequent intermittent doses, so say, for instance, I was give a drug, and you guys remember that term steady state? So I was give a dose, and it drops down, and then I give another dose, and then it starts to metabolize, give another dose. So see, I'm still keeping the drug level above the MIC, but I'm just having to give it more frequent doses, right? So I'm going to say every 6-hour dosing. If you see that, that's typically you're going to think something like a time-dependent killer. Okay, so as long as the drug level is above that MIC, I'm still inhibiting that bacteria. If I start to drop down below that, bacteria start to reproduce, and that can lead to resistance. That's what we worry about there. Is if you have the drug level too low, you see more likely to see resistance, and also you're not killing off that bacteria. More likely to see that infection continue on. Patient may not be getting any better. Okay, that makes sense so far? Yes, sir.
For the concentration dependent ones, are they typically the ones that have a wider therapeutic index?
That depends. Not always. You're going to see that you'll have some drugs that are, and so basically what it comes down to is that certain antibiotics you can dose based off, say, if I have a patient that weighs this much, or if I have an adult patient, I'm going to say, pretty standard doses. Say, for instance, I'm going to give you 500 milligrams every 6 hours. Okay, I don't need to do therapeutic drug monitoring on every antibiotic because their safety index is wide enough that I know that if I dose it based off these standards, I'm going to get good bacterial kill. I'm not going to worry about too much of the toxicity, right? As long as they're clearing it appropriately and all of that. Certain ones you're going to see, and there's going to be both time-dependent and concentration antibiotics that need to have therapeutic drug monitoring done. One, to make sure that your levels are getting high enough to actually treat the infection. So, for instance, here, if we were giving a drug, use green here. So, say for instance, I was dosing it, and I was only getting up to here, like you wouldn't really see a whole lot of bacterial kill. Patients not getting any better. It's because my levels are too low. So that's one reason why we might do therapeutic drug monitoring on that. The other thing is you want to make sure the levels don't get too high, because that's the way they can lead to things like organ toxicity. So we'll look at some specific examples of those as we move forward. But good question.
Is this one of the criteria we should know about each antibiotic?
This is something I will probably not ask a very specific question on. Is gentamicin a concentration-dependent killer? I'm not going to ask that question, but I'm going to say, hey, if I'm giving a concentration-dependent antibiotic, and say, for instance, they were to miss a dose, what does that mean for my patient or something, or something like that. So no more the concept behind it than necessary, because your patients are going to ask you when you're out there treating, hey, for my pneumonia, that penicillin you gave me, is that a concentration or time-dependent killer? You don't really care. What you want to know is that, hey, I'm dosing this every 6 hours because I know this is a time-dependent killer. I'm going to be able to keep that the level above the MIC. That's going to eradicate infection. That's why you need to take it every 6 hours, and not just take it every 12, right? Everyone marvel at my drawing ability so far? Great. Right. Okay, so this is another graph kind of showing you, again, kind of what I was already doing on the last slide. So maybe I'm just doing double work. That's okay. So again, looking at these dynamics, and this is one of the things where we can actually tell what our minimum inhibitory concentration is. So basically what they can do, and has anyone worked in a lab before doing any kind of testing like this? Okay, so no one can contradict me if I'm wrong. Perfect. So basically what you would see is you'd have varying concentrations of, you'd have different vials, say, containing a standard concentration of, say, the bacteria, right? You let them reproduce. And then what you change here is the level of the antibiotic. So say, for instance, here the antibiotic is in micrograms per ml concentration. Notice here at 0, it's pretty cloudy, right? Because it's full of the bacteria. As I start to increase that, it's going to get less and less cloudy. And once it's clear, that's where we know that, hey, we've inhibited all those bacteria. So I know that the minimum inhibitory concentration in this case, the first one that becomes clear, is 3 micrograms per ml. So I know that for that patient, that's the level I would at least need to get to inhibit those bacteria. Oftentimes we shoot for, say, 2 to 3 times above that just to be on the safe side, make sure we actually clear that infection, but that's basically the way they can tell what that MIC is. And so then for a drug that is concentration dependent, right? So we're shooting for a high concentration here, and then as that level drops down, even though it's going below the MIC, you're still not having that bacteria start to reproduce yet because there's that post-antibiotic effect. There's a period of time where the bacteria are kind of decimated. They can't really start to reproduce again. So if you see like every 24-hour dosing of a drug, that's usually what we're referring back to, is that concentration-dependent killing effect. Okay, versus something like something that's going to be more time-dependent. The time above this MIC is going to be really, really important here. So for the time-dependent killers, you want to maximize how long that drug level is above the MIC. So that's why we dose it, say, something like every 8 hours or every 6 hours, even though it's more impractical to do so. That way we can be sure we're actually going to kill off those bacteria. Okay, make sense so far? All right. So we're going to look at these different categories of antibiotics. Some important things to know. And again, we're going to talk about broad categorizations of the bacteria that these drugs will cover. Some things to know. If I say something has MRSA coverage, that's a good drug to note that coverage there. If I say something covers Pseudomonas, that's another good thing to note there as well. Okay, these are some key things to pick up on. Something has anaerobic coverage or atypical coverage. Those are also good things to note as well. Okay, and so we'll also note some other kind of broad categorizations. I'm not going to say, this patient grows, Klebsiella. Which one of these antibiotics is going to cover that? That's not really where we're at or where we're going to be at with this class. But if I say someone has, pseudomonal infection, which one of these penicillins can cover that? That is something I would want you to know, because that's, a pretty clear distinction. That is a good, that's what you need to know to make sure you're covering your patients appropriately. And we'll talk about those more in detail as we get to specific organ systems. But here I'm going to be focusing mainly on mechanisms of action, common side effects, common drug interactions. Those are things we're going to be looking at as we get into specific details on these different antibiotics. Okay. So starting off, this is actually not all of them, but this is where we're going to start off with. So these are going to be agents that are going to affect the cell wall. Okay, so these are going to be most oftentimes these are going to be bactericidal, because they are going to be able to open up that cell wall and kill off those bacteria. So these are going to be things like your beta-lactam antibiotics. We'll talk about why we call them that in a second. But this includes things like your penicillins. I'm sure everyone's heard of penicillin. Who's heard of like cephalosporins before? Anyone heard of like Rocephin? That's where this falls into this category of cephalosporin. We'll talk about carbapenems. Anyone heard of those before? These are like our gorillacillin. These are going to be really hardcore beta-lactams. And we'll also talk about this kind of oddball astringent here. But note, another good thing to note as well is going to be what generation that these cephalosporins fall into. Okay, because you're going to notice there's several generations, and this is going to affect what type of antibiotic coverage it's going to have. Okay, so we'll see that it will differ based on as you get into higher and higher generations of cephalosporin. Anyway, so penicillins, or beta-lactams in general, the reason why we call them that is because they have this beta-lactam structure here, okay? If you were to have, say, like the bacteria produce a beta-lactamase, an enzyme that breaks this open, your drug isn't effective anymore. So we'll talk about beta-lactamase inhibitors in just a little bit, but this is the main kind of business end of the molecule that we actually care about. What you will see variations of are going to be this R side chain. So if you guys are familiar, going to go back to your organic chemistry days, but this R side chain is what it can differ between the different penicillins, and so this can lead you to seeing, this is where we see a lot of issues with hypersensitivity. So we'll look at that just a little bit longer, and we'll talk about cross-sensitivity between penicillins and cephalosporins in just a few minutes here. So again, the way that these are going to work is you'll see this beta-lactam ring kind of mimics these two D-alanines, right? So if we're looking at the structure of the bacterial cell wall, we're going to see that they will have these kind of cross linkages that occur, and it includes these two D-alanines. You can kind of see here how if you were to have two connections between these two alanine, this is kind of what the structure looks like. Here's just another kind of confirmation of it. Notice here how it kind of mimics that same beta-lactam shape. Okay, so basically what this is going to do is try to mimic what the normal bacteria would be binding anyway, and there's a specific protein we're going to look at where that will inhibit that activity there. Basically what you see is that there's a cross-linking enzyme the bacteria produces called a penicillin binding protein. It's pretty easy to remember, right? So penicillins affect the penicillin binding protein, because again, that was the first thing we figured out that would actually bind to that. But basically, instead of working with those two D-alanines, it's going to bind specifically to penicillin, and this is going to cause a covalent linkage to occur and will inactivate that enzyme. Okay, so now the bacteria is unable to continue producing the cell wall because these enzymes are being inhibited, which means you're going to have eventual breakdown of that bacterial cell wall. It's going to lyse all of those contents out into the extracellular space, and then the bacteria is dead. Okay. You can kind of see here how have kind of multiple layers, but these cross-links here are really important to keep the kind of structure of the cell wall intact. And so when you inhibit these cross-linking from occurring, is we're going to have rupture of the cell wall. Again, spillage of contents, cell death. Make sense so far? Okay. Again, so even though it can still synthesize some of the components of the cell wall, it can't make those new cross-links, and that's what's ultimately going to kill the cell when we're dealing with these beta-lactam antibiotics. Okay. I try to use a kind of a stoplight kind of analogy for bacterial coverage. So these are kind of good broad categorizations, and we'll talk about any kind of specific examples when we get into individual cases here. But looking at our natural penicillins, so this includes basically our penicillin. So anyone have any of this growing in their fridge right now, by chance? Right, because it comes from mold, right? So you guys remember that's where it was originally discovered. Basically, penicillin G is kind of the original progenitor of antibiotics. It's kind of revolutionized the world of medical care when we had penicillin actually being discovered there. I will oftentimes put penicillin G, and then I will put like the brand name here in parentheses. If a drug is super old and doesn't really have a brand name that we use anymore, I might leave it off of here. But for the testing purposes, I will always put a generic name with the brand name. In general, I would recommend learning the generic name, knowing a drug by that. But in some cases, you know, people just call things Lasix, right? They don't call it furosemide all the time. They just say Lasix, or they'll say Ativan instead of lorazepam. So it's important to at least be able to distinguish between those. So on testing, I will always include both of those. Okay. All right, anyway, so looking at our coverage for natural penicillin, so these actually have pretty good activity against these gram-positive cocci. The one big thing to note here for our natural penicillins is it does not cover staph. So no Staph aureus coverage. So again, it could be useful for covering things like strep pneumoniae if it's not resistant, but it will not cover staph. It also has a little bit of anaerobic activity, but does not cover that Bacteroides fragilis. So this is why you don't see penicillin by itself being used a lot for like gut infections, because you wouldn't really have enough coverage for a lot of those anaerobes down there within that Bacteroides. However, though, it can be the drug of choice for certain disease states. So things like syphilis, you can use it for that. Gas gangrene, meningococcus, you know, those will all have pretty good coverage against penicillin for the most part. Again, no activity against aerobic gram negatives. So again, if you had like a UTI, which you would know once we kind of go over the urinary tract, hey, that's probably most likely to be gram-negative bugs. Penicillin is not going to be a good option for that. Okay, so those are kind of things to think about. I'm going to put dosing on here. I'm not going to have you guys memorize doses for my test. I will probably start to include more dosing, more doses on the actual test answers. That is more to get you guys starting to see it, to have it start to kind of imprint on your mind a little bit. I'm never going to have a question where I'm going to try to trick you up on is this dosing correct versus another one, right? So I'm not going to say penicillin, I'm going to put 6 million units every 6 hours. I'm not going to trick you guys on that, right? I'll put actual correct dosing on there just so you guys start to see it and start to kind of incorporate it. Make sense? Okay. So anyway, so notice here we dose our penicillin in units. So you normally say 18 to 24. And what do you notice to hear about how often we're giving it? Think it's like a time-dependent or concentration-dependent killer? Yeah, it's time-dependent, right? Because we want to make sure we keep our level high enough above that MIC to kill off those bacteria. So this is why we give it very frequently and say something like every 6 to every 4 hours in a lot of cases. Again, when you're giving these natural penicillins, you're always going to be monitoring for signs of anaphylaxis. And so what would be some signs of anaphylaxis? Hives, yep. You have patient feel that the throat's starting to close up. Rash, itching, hypotension, these are all things to be looking for. So anytime you give a new drug, you always want to be looking for signs of anaphylaxis. Again, it's kind of good practice, not just for penicillins, but again, certain patients are going to have more likely to have a reaction to these penicillins than others. So just keep that in mind. There's a few other forms of penicillin that we can give. Penicillin G is typically the IV form that we're going to administer. Looking here, we have penicillin V potassium. There's kind of the long names, phenoxymethylpenicillin, but this is the oral form that we can give. So if you ever see penicillin VK, that's that penicillin V potassium. That is the oral form that you can administer. The natural penicillin itself, if you give orally, gets destroyed by the gastric environment. It cannot be absorbed very well. But by giving this other form, the salt form of it, it gets stable in the stomach acid and can be absorbed there. So if you ever see the oral form, that's what it is. We also will have this other form. Anyone ever heard of bacillin? This is an interesting form. It's called benzathine penicillin G. The brand name is bacillin, and basically this is really good for intramuscular administration. You kind of notice here the kind of the milky color to it. It's actually put in this kind of lipophilic base. It needs to be injected into the intramuscular space. If I give this IV, this oil can potentially cause an embolus, and that's not good for my patient, right? I don't want to cause blockage of any of those kind of pulmonary vessels or anything. But the nice thing here is it has a really long half-life. So in some cases, if I have, say, a patient who comes in and they have, say, a strep infection, I want to treat with, say, something like penicillin, but they're vomiting constantly. They may not be able to take oral medication very well, and I also don't want to admit them to get antibiotics IV. So what I can do is just give them one dose of this bacillin, give it intramuscularly, and then they're good to go, right? Because the half-life is so long that I will keep the levels above that MIC, eradicate the infection, and then they're done. So that can be one of the nice alternatives to using IM is when they cannot tolerate oral medications. Okay. And that LA stands for long-acting. Okay. The next group you have are going to be your aminopenicillins. So basically, this is kind of the same beta-lactam structure, but now we're just changing that R side group to include these amino groups. So basically, we have things like ampicillin. This is available either IV or PO. You'll probably most likely see ampicillin being given IV. Again, I'm not going to have you memorize if the drug is IV or PO for the most part. There may be some specific indications where I'll ask that, but we'll cover those as I get to it. But in general, you'll see things like ampicillin being given IV, and then amoxicillin would be given oral only. So as anyone, I'm sure some people have taken amoxicillin, some people have taken augmentin. We'll talk about augmentin in just a little bit, how it's a little different there. But this is the oral form, so you use this very, very frequently. And so this has good positive, gram-positive cocci coverage. Again, very good for things like strep pneumo. Not going to be good for staph though, so no staph coverage here. Again, very similar coverage to your original penicillins, but you're going to start to see you have a little bit more gram-negative coverage here. A little bit more, but it's not going to be great as compared to some of the other antibiotics we'll talk about. But the nice thing here is that you can use this as a drug of choice for things like enterococcus. Use this for things like listeria, endocarditis. What is endocarditis? Yeah, it's an infection of the heart valve, essentially. So we'll talk about endocarditis a little bit later. But you can use this for prophylaxis to actually prevent an infection due to things like certain gram-positive bacteria. You can use this for upper respiratory tract infections. So you use a ton of amoxicillin for sinusitis, otitis, bronchitis. You use very, very frequently. So this is kind of a good run-of-the-mill antibiotic you're going to use very frequently in your career. And they can also use for community-acquired pneumonia. That's what CAP stands for. If you ever see HAP, that is hospital-acquired pneumonia, that would be a different type of bacteria spectrum. This would oftentimes not be good enough coverage for that sort of thing. But for community-acquired pneumonia, someone comes walking off the street, this might be a good antibiotic for them. And then a lot of times you might actually see your dose will change depending on what type of infection you're treating. So certain things like strep pharyngitis, very easy to treat. I don't have to give a very big dose, but for pneumonias, you'll find that for a lot of antibiotics, the lungs are very difficult to penetrate, and so we use higher doses there. So this is where we use like high-dose amoxicillin in those cases. Again, notice we're giving this every 6 hours, every 8 hours. These are still time-dependent killers. All these beta-lactams are going to be time-dependent killers, so you need to be giving them more frequently for the most part. Unless they have a really long half-life, like that bacillin I mentioned. I'll mention a cephalosporin a little bit later that you can give just one time a day. But in general, these need to be given very frequently. Some of the things you'll notice with these penicillins is that they can have some interaction with anticoagulants, meaning they can actually lead to prolongation of your prothrombin time, which we know is you guys have covered prothrombin time previously? Right, so it's a measure of how quickly your blood's going to be clotting or not. So sometimes you can see some interactions here where you actually can have prolonged clotting time. I've never clinically seen this actually pop up ever, but just to be aware that's a possibility. And then there's always this risk for decreasing effectiveness of oral contraceptives. So has anyone ever heard the sage wisdom that if you're on antibiotics, you should use backup form of contraception? Some people probably heard this. The evidence for that is probably not 100% there. A lot of times you'll find that we have what we call medical dogma, which are things that have been carried on through the decades, but we actually don't really have any good evidence for. This is probably another one of those things, but still, when the consequences are possible pregnancy, pretty severe consequences I'm living through right now, it's probably okay to use a backup method, at least for the 14 days you're on the antibiotics. Essentially, the reason why they recommend that you use a backup form of protection in these cases is because, you guys remember that term we mentioned, enterohepatic recirculation? Hopefully. So what does that mean? Enterohepatic recirculation. Yeah, so you see certain hormones, especially your estrogens, they get kicked out through the biliary tract, right? So they go with the bile salts through the biliary tract, and they get reabsorbed through the gut. It has to be metabolized by the gut bacteria first before it can be reabsorbed. And so you have this recycling where the effective half-life of those estrogens are longer based on this recycling than it would be just based on, if you did not have that there. So the worry is if you get antibiotics, you disrupt that normal gut flora. You don't have that recirculation. Your estrogen levels drop, and then you have the potential for what to occur? Ovulation, right? And that's the thing we're trying to prevent by giving these exogenous hormones. So you can remember, like, the physiology is all coming back, right? Hopefully. You guys wonder why I made so many drug examples in physio. This is why, because all this stuff comes back. Anywho, so again, clinically, I would probably recommend this just to be on the safe side. Again, a lot of people probably do not want a surprise pregnancy, so it's just easier to do that, to recommend that. Anyway, other side effects you can potentially see with these penicillins, you can see risk for hepatic dysfunction, which can be evidenced by things like hepatitis. You can see jaundice, which is kind of a buildup of what? Bilirubin can build up there. Sometimes you can see things like ALT, AST start to peak up. So those would be things to look for there. And also, for some antibiotics, this is more prevalent than others, but there's always a potential risk for having anything that has anaerobic coverage will have a risk for developing C. difficile infection. Okay, so this is probably, these penicillins are not going to be the most common ones to cause C. diff infection, but there's a risk always. Anytime you're disrupting the normal gut flora, you have a risk for having C. difficile take hold, and it can cause C. difficile infection. Okay, what can we give to potentially prevent that? Yeah, so probiotics are potentially, that's where we're giving healthy bacteria in order to try to help reestablish colonization of normal, relatively normal, helpful flora, rather than having something like an opportunistic infection come in there. So that's one thing we can potentially do to prevent that. You also want to be wary of any kind of skin manifestations that can occur after giving penicillins. So we have two conditions, one called Stevens-Johnson syndrome, and one called toxic epidermal necrolysis, or TEN. Have you guys ever heard of these? Does anyone know what it kind of manifests as? Yeah, so it can start off with like very severe rash. It can start off with blistering of the skin. Basically, it will fulminate, and basically the skin just kind of sloughing off in huge sheets. It can be very potentially fatal if not treated early and aggressively with lots of good kind of supportive care. So anytime you have a patient who's complaining like, hey, I have these like new blisters after I started taking this penicillin, that's a worry. That's a big worry sign, right? That's something you need to have them come in, get evaluated for immediately, discontinue the medication, get them switched on to something else. So it's always a risk there. Some risk for having renal dysfunction. So you can have what we call interstitial nephritis that can happen, some intrinsic kidney damage happening there. So again, you want to monitor for the renal function. And again, penicillins are going to be renally eliminated. So you need to watch for renal function to make sure they're not going to have buildup of these drugs to potentially lead to more risk for some of these adverse effects. Okay. Obviously, patients who have contraindications here would be ones that are allergic to penicillin. So you don't want to give them penicillins if they're already allergic to it. If they have a history of any kind of hepatic dysfunction, that is kind of a relative contraindication, right? And so one of the distinctions to make is something an absolute or a relative contraindication. Absolute meaning what? Patient should never get it, versus relative meaning a patient may be able to get it depending on kind of what's going on. If they have a history of, say, hepatic dysfunction, it was 20 years ago and they've had a perfectly fine liver since then, I'm probably not that worried about it. Versus if I know they've had a true type 1 allergy to penicillin previously, I'm not going to re-challenge them, right? Because I'm just asking for trouble. Okay. Again, worry about the renal function, monitor for this at baseline. For most healthy patients, you may not need, so if you're just treating like an acute otitis media, if they're otherwise healthy patient, I probably don't need to worry about the renal function. But if they're, tiny old grandma, and I know their renal function probably has been on a downward trend, maybe check a renal function beforehand, right? Other things to look out for: rash, diarrhea. So again, anytime you're giving antibiotics, you can potentially see some stomach upset. These things all to worry about. Again, not always routinely done, but look at renal function, hepatic function, and platelets, because again, that can lead. If you have increased bruising, bleeding, anything like that, that should be a sign. Hey, we should check a CBC, look at their platelets. So in the rash, you can kind of see with the penicillin. Okay, so the reason why we see resistance to our penicillins is due to a product called beta-lactamase. Basically, it's an enzyme that the bacteria can start to produce that will cleave this ring here, and once that is broken open, it is unable to bind to that penicillin binding protein. The drug is ineffective now. Okay, so we have some ways that we can circumvent this, and that is by giving a beta-lactamase inhibitor. So as you might imagine, it's going to be another product that will go in and prevent that beta-lactamase from working. It leaves your penicillin available to work on that penicillin binding protein and keeps its activity up. Okay. This is very important to know when we should be using this combination versus not. So some examples of beta-lactamase inhibitors that we're going to see here. So sulbactam, tazobactam, and then we also have clavulanic acid. If you ever see clavulanate, that's just another form of it. Basically, you'll see these in combination. These are never given by themselves, because again, they don't have any intrinsic activity for treating the bacterial infection. They only work to inhibit that beta-lactamase. So you'll see things like sulbactam will be mixed with the aminopenicillin ampicillin, and now you have a drug called Unison. Okay, you'll have tazobactam being added with another drug we'll talk about a little bit later called piperacillin. This will cause gets the drug Zosyn. Anyone ever seen Zosyn given before? Yeah, very broad spectrum antibiotic, very good for treating lots of things. And then obviously everyone's probably heard of Augmentin before. This is going to be clavulanic acid mixed with amoxicillin. This is an oral medication. These other two are IV only, but this is an oral medication that is very frequently administered on the outpatient side for treating a host of usually upper respiratory tract infections. Okay. The benefit here of giving this beta-lactamase is it also helps to broaden the coverage of the antibiotic, so it's effective against more bacteria than it would be by itself. Yes, ma'am.
So for the beta-lactamase, that's something that bacteria is producing, which is like for resistance, correct?
Essentially, yeah. So here we're going to talk about the aminopenicillins with a beta-lactamase inhibitor. So the primary ones we're going to talk about in this case are going to be Augmentin, which is that amoxicillin plus clavulanate, and the Unison, which is ampicillin plus sulbactam. I know this is a little backwards what I said I would normally do, but this is how it is. Again, still time-dependent killers. You're still giving it pretty frequently, every 8 to 6 hours or so. And again, you're going to see that now we have broader anaerobic coverage. That's probably okay gram-negative coverage and still pretty decent gram-positive coverage. You won't see MRSA coverage, but you will see it now starts to cover MSSA. So it's broadened it out enough, so now we can actually start to treat some of the more kind of minor variations of Staph aureus. Okay, so it's kind of one of the nice bits of increased coverage. You're going to see now it starts to cover more of the anaerobes, so now that Bacteroides fragilis we mentioned before is now covered. And so this means it's going to be very good for treating bacteria or infections where you're thinking skin flora, you're thinking anaerobes, and so you can see things like skin and soft tissue infections, diabetic foot infections, right? So why do diabetics get foot infections? Right, so they have high sugars. Bacteria love sugar, so that it kind of gives them a more preferable environment for bacteria to grow. What's the other big thing with diabetics? Yeah, they have neuropathies, right? So they have kind of chronic neuropathies that occur, so they don't feel, even if they stepped on a nail, they would potentially not feel it, right, or something like that. So they can get these infections that develop, and especially if they're not able to really check their foot, constantly, pretty regularly, they can develop these really nasty infections. And so imagine your foot being in a shoe covered up with a sock. You have a nail puncture or something like that. It's a very good anaerobic environment. You have some gram-positive skin flora getting in there, so you can see lots of different bugs possibly growing there. So you have to widen out your coverage, right? So that's why we use things like Augmentin here, or we use Unison to treat those. Also, we mentioned what type of bacteria were growing in the mouth. Peptostreptococcus, which are what type of bacteria? Aerobic or anaerobic? Anaerobic, right. So now we need to cover, if you ever would have an animal bite or a human bite, we do see those, you need to cover for those anaerobes now. So that's why we use Unison or Augmentin as our treatment of choice for animal bites for the most part. We actually had an alligator bite at Nemours not too long ago. I can't remember what we were covering for, because when you have aquatic animals, they have a little bit different coverage. They have things like Vibrio and different things like that. But in general, if you were to have a cat bite, a dog bite, or a person bite, if you were to have like Mike Tyson over or something like that, and you need to treat that, timely reference. You basically need to treat with something like an Augmentin or a Unison, because you have that anaerobic coverage now, in addition to that gram-positive skin flora, right? Okay, then moving up the chain of our penicillins, now we have penicillinase-resistant penicillin. So this is another enzyme that the bacteria can produce that will just break down the penicillin and make it. That's why a lot of times you're going to find that those kind of earlier aminopenicillins and just penicillin by itself didn't really have good coverage against MSSA, is because they developed this penicillinase, which would break them down. So now we have what we call the anti-staphylococcal penicillins, and this is the category that methicillin would have fit in if we still used it clinically nowadays. The three that we use nowadays are going to be nafcillin, oxacillin, and dicloxacillin. Okay, those are going to be our anti-staphylococcal penicillins. These are primarily designed solely to cover MSSA. Okay, because it has a very kind of narrow spectrum, we don't use it as a lot for empiric therapy because, again, it wouldn't cover a lot of like a broad spectrum of bugs if I wasn't sure what the cause of the organism is. So this is a good drug that the patient, I'm treating them empirically for an infection, comes back as MSSA that is sensitive to something like dicloxacillin. I can pare down my therapy and just use one of these as my sole drug. All right, so this is good de-escalation drugs that I can use potentially. So again, oftentimes you're going to see that your MRSAs, if you were to say if you're covering for MRSA with certain drugs, you can de-escalate down to one of these when it comes back as MSSA in those cases. Okay. Again, very similar side effects you're looking for, similar monitoring. The only distinction here is just what they're going to be covering for as far as bacteria go. Okay, and then we have some of my favorite, going to be the anti-pseudomonal penicillin. So anti-pseudomonal, think what type of bacteria is it going to cover? Pseudomonas, yeah, Pseudomonas aeruginosa, which is a very, very virulent bacteria. We're going to find that within the penicillin class, we really only have piperacillin. Okay, there's probably one or two more, but clinically we really only use piperacillin out there. So piperacillin by itself, I've never actually seen piperacillin used by itself. I always see it used as piperacillin and tazobactam. Tazobactam being what? As a beta-lactamase inhibitor. So Zosyn, if you're here, Zosyn is a very common drug. This is the one that is very easy to overuse because what do you notice here about the coverage? Yeah. Green all the way, right? So I can probably give most of my patients Zosyn. They'll probably get better. And so it's very easy. So I see a lot of overuse of this because you don't have to think about it. Just set it and forget it. A lot of cases that's not appropriate, right? Because we need to put a little bit more thought into it to see if we can de-escalate that coverage for the most part. So what you see here, very good broad spectrum coverage. You're going to have MSSA only. You're not going to have MRSA coverage yet, so you won't get that. But you're going to have anti-pseudomonal activity. So again, this is a good thing to note. What drugs cover Pseudomonas? Okay, so this is one of the ones that will cover Pseudomonas. And so this is really good for polymicrobial infections. If I'm worried about multiple types of bugs that are causing an infection at the same time. If I'm worried about nosocomial infections, so ones that the patient picked up from the hospital. So, for instance, pneumonia is a very good example of Zosyn use. If I have intra-abdominal infections, right? Because, again, when I'm dealing with the intra-abdominal cavity, I'm worried about gram-negatives. I'm also worried about anaerobes. This is going to cover both of those, okay? And then also pseudomonal infections. And, again, if I know the culture comes back with Pseudomonas, I can use this in order to treat that, okay? So in this case, where I use Zosyn most often is a lot of times for complicated intra-abdominal patients. So for instance, if I were to have a patient who's coming in for an appendicitis and it turns out it ended up rupturing, right? I'm worried about a lot of translocation of those gut bacteria. I use Zosyn to help cover gram-negatives and those anaerobes. I use it a lot for intra-abdominal infections. Okay, a lot of people will use Zosyn for pneumonias. I try to hold off on that because the spectrum is so broad that I really don't need to worry about. We'll talk about that in the pulmonary section, but just know Zosyn gets used probably a little too often just because of its ease and because it covers so much. Okay. It's starting into that gorillacillin category. And again, notice here is still going to be given every 6 hours, so still time dependent. Some people actually will end up doing what we call these extended infusions, where you actually give the drug over 4 hours. That's just kind of a point to show that there's different dosing strategies you can use. Again, by giving over 4 hours, what am I doing with the drug levels? Keeping above that MIC for a longer period of time, right? So that way I know. And so having the peaks and valleys is going to be much more consistent over that time period, more likely to kill off those bacteria. Again, watch your renal function. Looking still for the similar adverse reactions with the other penicillins we see, and again, looking for similar monitoring. So renal function, look at the CBC for any potential bleeding. Again, clinically, bleeding doesn't pop up that often, but just be something to think about. Okay, so those are the penicillins you want to know about for testing purposes and also for your clinical life, right? Because that's what we're really worried about is your clinical experiences, not necessarily for the test. I know you guys are concerned with the test. But moving on, those are penicillins of note. Now we're going to talk about the cephalosporins. Okay, notice here the cephalosporin still fits into that beta-lactam category, so this is still the business end of the drug. Still going to be doing the same mechanism, binding to those penicillin binding proteins, still inhibiting those cross linkages, causing the cell wall to break down and causing the bacteria to lyse up contents and die. The only thing different here is going to be their structure. So a little bit different R chains, kind of R1 and R2 chain here, and just different structures. But again, you're going to find that the spectrum of activity is going to be differing based on these side chains. And again, we'll talk about different generations of cephalosporins and why that's important. So, cephalosporins, some good things to note here. One, they have good CSF penetration. So we mentioned the CSF can be very difficult to penetrate due to the presence of what? Blood-brain barrier. You guys remember what cells produce that? Astrocytes, yeah, absolutely. I'm glad you didn't dump everything in 2 weeks. But you have the astrocytes that bring that blood-brain barrier that's really trying to prevent really any foreign material from getting into the CSF. But we need some drugs to be able to cross there, especially when we're dealing with what type of infection. Meningitis, yeah, that's a big one. So that's why you always see a cephalosporin being used for coverage of meningitis, because it's good CSF penetration. Some drugs are just too large to cross over into the CSF, right? Just there's a physical incompatibility there. Some drugs are going to be subject to those efflux pumps we mentioned before, like that PGP that just spits it back out into the bloodstream. But these are going to have a pretty easy time getting across. You're also going to find that when you have meningitis, you're going to have inflammation of the meningeal lining, and that's going to allow for larger holes to occur, the larger gaps to happen in the blood-brain barrier, that will allow for certain antibiotics to cross over there as well. So just something to note. But anyway, cephalosporins are good for that. Note here that when people say that I have a penicillin allergy, there is a concern that, and traditionally what was done is that if someone had a penicillin allergy, even if it was a true penicillin allergy or if it was kind of a bogus one, they would say, well, you cannot receive cephalosporins because they're both beta-lactams. There's too much of a cross-reactivity there. If you have an allergic reaction to penicillin, you're going to have an allergic reaction to cephalosporins. That is not the case. Okay, so I'm here to hopefully break that myth for you guys. There's a very, very low chance of ever having a cross-sensitivity. Again, most of the people who say they have penicillin allergy, it's not a true anaphylactic allergy. It's, oh, I had diarrhea, or I threw up, or my mom said I had a penicillin allergy because I had it once when I was a kid. Okay, you don't want to wipe out this entire spectrum of drugs to use for those patients, right? Because again, you're dozens of drugs you potentially can't use based on this someone saying they have an allergy. Clinically, even if they really had a true type 1 allergy, there's less than a 1% chance that they will have a cross reaction and have an allergy to the cephalosporins. So you can use these safely. A lot of times I'll still have practitioners, especially older practitioners, who say, oh, I'm not really sure about this. I don't want them. I was like, well, give them a dose here in the hospital, give them a dose in the ER, see how they react. And if they do well, then send them home and they're fine, right? So that's one way to get around it. Sometimes I have to do a little arm bending in order to make people see that, hey, there's really not a big risk there. But some people will still say, no, you can't do that, but just be aware that it's very, very low risk. That's based on evidence-based medicine, right? Very similar side effects to what you would see with the penicillins, nothing really big different there. And the big thing to note here is that the spectrum of activity is going to be very dependent on the generation that we're dealing with. Okay, so we're going to talk about first, second, third, fourth generation cephalosporins, and so the coverage will change depending on what generation we're dealing with. We'll talk about that in just a second. As far as anti-pseudomonal activity, we're going to talk about a few of them. The big ones you're going to see being used is probably most often cefepime. Cefepime is a very good anti-pseudomonal drug. We'll also talk about ceftaz a little bit, ceftazidime, but we'll get those in just a few minutes here. Again, almost all of them are going to be renally eliminated, so you do have to watch renal function to make sure the patients are not building up levels, potentially having any issues with that. We'll talk about one notable exception just a little bit. Okay, so looking at the generation progression here, so as you move up in the cephalosporin generation, you're going to have more gram-negative activity being seen. So if you're looking at gram-negative activity from first to second to third to fourth, you're going to see more gram-negative activity, okay, which is a good thing. As far as a gram-positive activity, which you're actually going to see is it starts up at the highest when you're doing the first generation. It's going to dip down as the second and third generation, and then as you get to fourth, it's going to start to peak back up, okay? We'll talk about what that means in just a few minutes when we get to the individual generations, but this is a good kind of generalization to make here. So the higher generation, the more gram-negative coverage, usually the worse gram-positive coverage until you get to the fourth gen. So first generation cephalosporins. This is going to include our cefazolin or cefazolin. Either way you can say it'd be fine. This is Ansef. Anyone ever heard of Ansef before? a very common IV drug that we use a lot for surgical prophylaxis. This is one of the probably the most common antibiotic we give just on a day-to-day basis in the hospital because we give it to our surgical patients. Probably 95% of them end up receiving ANSEF for surgical prophylaxis, right? So they don't have an infection, but because we're cutting into them, we want to make sure we prevent any infection from occurring. So again, we're covering for those type of skin flora, and so that we can cover for things like MSSA, right? So that's a good coverage for that with that cefazolin. You're also going to see that it will help with UTIs. You can potentially use ANSEF to cover for some of those. It doesn't have great gram-negative coverage, but it has enough to where you can treat most things like some minor E. coli, Klebsiella, things like that. Next we have Keflex. Anyone heard of Keflex or cephalexin? Yep, that's very common. This is a very common PO or oral medication that we'll use. So probably if you're looking at the most common antibiotics you're going to prescribe on the outpatient side, it's probably amoxicillin. It's probably going to be Keflex next, right? So we use this a lot for certain skin and soft tissue infections because of its good gram-positive coverage. For things like cellulitis, certain abscesses, we may use this, and also potentially for some more kind of minor UTIs, you might utilize this drug. Again, you'll note that it's still time-dependent killing. So again, you're going to be giving it still pretty frequently. Sometimes Keflex you can get away with giving every 12 hours or so, but usually every 6 to 8 or so is how often you're going to be giving this. Good gram-positive activity. And something to note here with all the cephalosporins is none of them are going to cover Enterococcus. So it's kind of a hole in coverage that you need to be aware of with your cephalosporins, because if you're thinking Enterococcus, this is not going to be a class of drugs you want to use for them. Okay, so any cephalosporin. But you'll see a little bit of gram-negative coverage, so E. coli, Proteus, Klebsiella, so this is why you can utilize it for UTI coverage, because these are probably some of the more common causative organisms in UTIs. Moving on, we have our second generation cephalosporins. I probably see these used the least often clinically out of all the cephalosporins. You have a few IV options here with like cefotetan, with cefoxitin. Cefuroxime is actually a PO or variety, and then cefprozil. I'm going to try to do a better job actually enunciating all the drug names so you guys are at least familiar with how I say them. Again, there may be some discrepancies here or there. Don't make fun of anyone just because they say a drug name wrong, especially your patients. I had one guy ask for CLA one time. Guess what he's asking for? Is KCl, potassium chloride. Yeah, so people say lots of weird things, so just be aware of that. Anywho, you're going to find the second generation cephalosporins are going to have a little bit more gram-negative activity in your first generation. So you get more things like H. influenzae, Enterobacter in some cases. You do see a lot of resistance happening with that, so we don't use that routinely. But also Neisseria, Proteus, you're going to see better coverage. So you maybe use these for like UTIs in some cases. Sometimes use this for surgical prophylaxis, but again, not super common as compared to a lot of the other cephalosporins. So just be aware these are the second generations. That we can use these for some of these gram-positive and gram-negative infections, but not used very commonly. Next, we have our third generation cephalosporins. These are very, very commonly used. These are very good gram-negative and some minor gram-positive coverage, but you see these a lot for gram-negative coverage. So one of the big ones is ceftriaxone or Rocephin. I'm sure most people have heard of Rocephin before. So this is a very good kind of more broad coverage kind of antibiotic. We use this very frequently for empiric coverage of lots of different types of infections. So for instance, if I have a patient who has sickle cell disease and they come in with a possible infection, I give them ceftriaxone because I know it's going to cover most of the things they might have there. Certain patients who are immunocompromised, ceftriaxone may be okay for them. The nice thing here is that this one actually has no adjustment for renal dysfunction. So if I have a patient who comes in, they say they're septic and they have really poor kidney function, I can give them this drug with impunity because it really relies on hepatic metabolism. That's one of the nice things. The other big thing with ceftriaxone is it's only given one time a day most often. Sometimes you'll see it used twice a day for things like meningitis, but it has a very long half-life. So that's why we can give it one time a day for the most part, and you get very good coverage for that, even though it's still a time-dependent killer. Okay. Very good strep coverage. We use this a lot for potentially resistant strep pneumoniae for some of those upper respiratory tract infections. And the other big thing you want to watch out for is you cannot use this during the first 30 days of life. There's an interaction here for those infants when they're coming in, is that you can displace bilirubin from albumin. Right, so remember, albumin is one of those really important plasma proteins. If we displace the bilirubin with ceftriaxone, that can cause jaundice for those babies. So we don't want to do that. So we'll actually use a different type of third generation cephalosporin for them instead. Okay, so again, first 30 days, do not use ceftriaxone for those kids. And then we also want to avoid mixing with calcium. You can see precipitation when you give that either in the line or in the patient themselves, and it can potentially lead to embolus. You don't want to do that. So this one's only IV. You give it IM as well. Very good to give. Sometimes we'll have patients who cannot tolerate oral medications, and we'll actually give them 3 days worth of IM Rosef, and they'll come back into the ER for 3 days and then get good coverage for where their infection might be. Cetazidime, this one we don't use too frequently. It has a little bit of pseudomonal coverage. I use this mostly with my CF patients with cystic fibrosis. But again, clinically we don't use this one super commonly just due to rapid resistance with that. Cefotaxime, though, is a very common one you use for neonatal sepsis. So if you have a patient who goes home after being born, they come back with a potential infection, fever. Anytime you have a fever in an infant, you need to determine what it is, especially that first 28 days, because it could be meningitis, it could be sepsis. You need to treat that pretty quickly. And so cefotaxime is one of the ones we use for that most commonly, because again, it's another IV product, but it does not have that same interaction that Rocephin does. Okay. As far as an oral option, we have Cefdinir, we have Cefixime or Omnicef or Suprax. These are good oral options for third-generation cephalosporins we use pretty commonly. Again, better gram-negative coverage than your second-generation agents, but we're losing more of that gram-positive coverage. So you won't necessarily see this a lot for like skin infections or about skin flora, but you will see it for like UTIs, pneumonias, other type of infections like that. Okay. I think I'm asking if you have any questions. Yeah, so just a little bit of dosing here. So again, just know that Rocephin you can give pretty infrequently, say like 1 time a day, sometimes twice a day for more really severe infections. But for the most part, it's nice because of the long half-life there. But any other questions I can answer for you guys? Okay, his brains are already fried. Okay, we'll have more of this tomorrow. All right, sounds good. Okay, I'll see you guys then.